All right, so thank you, Alice, and all of the conference organizers for inviting me to speak today. I will be speaking about HIV testing, specifically HIV diagnostic perils and pitfalls from pregnancy to PrEP and beyond. I have no disclosures other than the fact that I work for the NCCC, which is one of the national AETC programs mentioned here. Our objectives for this afternoon are first to describe the basic testing algorithm for HIV diagnosis here in the United States. Second, to name at least 3 common causes of ambiguous HIV test results. And third, to explain how to approach confusing or uncertain test results in common clinical scenarios, including pregnancy in people who are taking pre-exposure prophylaxis. So I want to start by just asking the question, why should we even talk about HIV testing? It seems really basic and simple, right? Pretty straightforward. But I think there are 3 key reasons why we should have this talk at all at this type of conference. The first is that HIV testing is still vastly underutilized in the United States. According to the CDC, almost 15% of people in the US who are HIV infected don't know it because they have never been tested. And that's not surprising when you look at the next statistic here, which is that fewer than half of all adults in the US report that they've ever been tested for HIV. Moreover, over half of women and nearly 2/3 of men in groups that have historically been labeled as high risk have not been tested within the last 12 months, in spite of recommendations to do so. Second, I think it's important to talk about HIV testing because there actually have been changes in some of the recently approved tests as part of the diagnostic algorithm, and we'll go over those. And third, as we will see, it can sometimes be difficult to interpret the results, particularly in the era of LA PrEP. So we'll start with a case. This is a patient that I helped take care of back when I was working in Lawrence, Massachusetts. This is a 28-year-old woman who is experiencing opioid use disorder. The rest of her medical history is listed there. She was only taking albuterol as an active medication at the time of her visit, and she presented to the mobile health clinic where I was working, asking for buprenorphine and was in active opioid withdrawal. On further questioning, you learn that she had overdosed 2 days prior. She also reports a history of exchange sex. She denies any recent history of sexually transmitted infections. She also denies ever having shared injection-related equipment. And importantly, she says that she has no known history of hepatitis B or renal disease. And in the last 4 to 6 weeks, she has not had any recent fevers, rash, or flu-like illness that would be concerning for acute HIV. So in addition to discussing treatment for her opioid use disorder, you also discuss HIV testing and prevention options for her. So this brings us to our first audience response question, and I'm sorry that we don't have the technology to actually answer these questions live, but you can do them in your head. Which of the following tests is the preferred initial HIV screening test for this person according to current CDC guidelines? Is it a qualitative HIV nucleic acid test? Is it a quantitative HIV nucleic acid test, also known as a viral load, a Western blot, a rapid test, a standard HIV antigen antibody test? Should you do both, a rapid test and one of these quantitative NATs, or should you do something else? Lots of options there. I haven't even written them all down. So, all right. So while we think about that, I think it's really helpful before we go into the current algorithm for HIV testing to review this very well-known figure that describes the traditional sequence of lab marker appearance for HIV-1. And as you can see here, the first marker, serologic marker to appear after HIV infection is the HIV RNA, which is commonly known as the viral load. That usually appears around 7 to 14 days after the initial infection, and that's followed closely by the P24 antigen, which shows up around 14 to 21 days. The HIV antibody, usually the IgM, does not appear until at least 3 weeks after that initial infection, using the most sensitive assays that we have, and sometimes it can take even longer. And one of the things that I wanted to note here is that the period in between HIV infection, and when the markers appear is known as the window period. So the window period varies based on exactly which marker you're referring to, and that will become relevant later on. So this is the standard HIV testing algorithm that the CDC first proposed back in 2014, and it starts with an HIV 1-2 antigen-antibody combination immunoassay. When that test is negative, in most cases, we can say that that person is not infected with HIV. There are some exceptions to this, and we'll bring some of those up as we go on in the talk. But as a general rule, if that is negative, if that screening test is negative, we can say that person is uninfected. If that test is positive, then we then go to a second step, a second test, to confirm the presence of HIV. And according to this algorithm, what we are supposed to do is an HIV 1-2 differentiation assay. If that's positive, then HIV infection can be confirmed. If it's negative, then we have to do another test to clarify the diagnosis. And historically, what we have done is a standard HIV RNA viral load or nucleic acid test. Interestingly, that standard HIV viral load cannot be used to officially diagnose HIV. All right, even though the presence of a positive viral load does give compelling clinical evidence that this person has acute HIV if that second test is negative. If the HIV viral load itself is negative, then what we would say is that that first screening test was a false positive. All right, so that's the standard algorithm. After 10 years of almost no changes in the testing algorithm, the CDC recently updated the algorithm to incorporate three recently FDA-approved nucleic acid tests that can be used for HIV diagnosis. All right, so unlike the standard quantitative HIV viral load that most of us get in practice to monitor treatment in people with HIV, that cannot be used to confirm diagnosis. These new tests, these new nucleic acid tests can, and there are a couple of different ways that the CDC says that they can be incorporated into the testing algorithm. The first is shown here on this slide, where it basically just replaces the standard RNA to help diagnose people with acute infection. The second is shown here on this slide, and here you can see that the nucleic acid test with a diagnostic claim, in other words, that the test that can be used for diagnosis, replaces the differentiation assay as the second step in the algorithm. And so if the first antigen antibody screening test is positive, then you can proceed directly to this HIV nucleic acid test. And if that is positive, then you can say that that person is infected with HIV. One important thing to note that the CDC is quick to point out, which is that if you use this algorithm in practice, it is very difficult to actually distinguish between chronic and acute HIV. All right. The only way to do so is if you have an antigen antibody assay that can distinguish between P24 and antibody positivity. And if you have P24 positivity alone within the presence of a positive HIV-1 NAT, then you can say that person is acutely infected. But otherwise, and a lot of people are not using that technology yet. You cannot distinguish between acute and chronic using this particular algorithm. Just to let folks know what these newer nucleic acid tests are that have been approved for diagnosis, there are three of them. The first two that I listed here are specific for HIV-1, and they provide both qualitative results, meaning yes, no, and quantitative results, meaning they'll give you a reflex to viral load if the result is positive. The other test that has been approved for diagnosis is a combination HIV-1, HIV-2 nucleic acid test, and this can differentiate between HIV-1 and HIV-2. However, it does not provide quantitative tests. It provides quantitative results. It provides qualitative results only. Now, I wanted to also just take a minute and talk about some of the basic differences between the screening tests that are used most commonly in practice, because we don't often think about these, but they actually can have some real implications in terms of their clinical utility and how we use them in practice. So there are two main buckets in terms of the types of tests that we use for screening tests when we talk about screening for HIV. The first are instrumented tests, and the second are point of care or rapid tests. And I think we all know from practice that what's most commonly used in the clinic setting would be the rapid tests. These are tests that use relatively simple technology, similar to what's used for a pregnancy test, and that provide rapid same-day results. They usually require only just a finger stick, right? So no venipuncture involved, and can be very useful in certain clinical situations where a rapid result is required. However, there are some potential drawbacks to this the point of care tests. One is that most point of care tests that are used in practice are tests for the antibody alone, right? So there's a longer window period when you're using these tests. So for people who may have recently been infected, this is less ideal. The second is that they are less sensitive than the instrumented tests that are used. And the third is that they cannot be used to confirm a diagnosis of HIV. So if that test is positive, you then have to go do a venipuncture on this person and send that sample to the lab for confirmation. Now, the instrumented test uses a slightly more complicated laboratory technology. There are 5 or more of these different platforms that are available that are employed by different labs. These are more sensitive. They also, all of them include the antigen test, right? And so there's a shorter window period, but they also do require venipuncture, which can be a drawback, and the results are not as rapid. And so there can be loss to follow-up in between the time that the sample is drawn and when the results are reported. So that leads us to our next case, which is a case that we received on our HIV perinatal hotline. So we have a number of different lines with the National Clinician Consultation Center, one of which is for perinatal HIV. And we were called in mid-August of 2021 by an HIV provider in the Midwest who was caring for a patient who was 36 and 22 weeks pregnant. She had conceived via IVF. She was born and raised in Ethiopia, and because of that, the caller did not have access to her vaccine history. She reported a single sexual partner and had no information about his HIV testing history. She herself, however, said that she had been tested for HIV previously prior to the pregnancy, and that was negative. However, repeat testing during pregnancy demonstrated the following results. She had a positive antigen antibody that was followed by a reactive HIV-1 antibody and an indeterminate HIV-2 antibody. But the HIV nucleic acid test, the viral load, was undetectable. Another important test result to help orient you here is that she had an initial hepatitis B surface antigen screen that was positive, but the confirmatory test was negative. In looking at all these results, and because this person was pregnant, the provider started this person on ART, but called us to see, was this the right thing to do? At the time of the initial consultation, we said, it looks most likely like this person is HIV infected. We would call this somebody with this pattern of test results an elite controller. And because she's pregnant, starting ART does make sense. However, we agreed that there were some interesting aspects of the baseline testing, and so we recommended some follow-up testing to help clarify the diagnosis. So the provider called us back a couple months later, at which point this person's now 31 weeks pregnant, and let us know that he had been able to send off a sample to the University of Washington, where they did an HIV-2 RNA that was non-detectable. He repeated the HIV-1 RNA, and that was also undetectable, although again, at that point, she had been on ART for 3 weeks. He also asked his lab director to rerun the samples that had been drawn in August, and the lab got the same exact results, making lab error much less likely at that point. He also did what I'm going to call, for the sake of simplicity, a modified Western blot. That modified Western blot showed a positive GP41 envelope protein, but a negative GP160. And without getting into all the nitty-gritty details of protein band interpretation, this would basically be interpreted as an indeterminate result. He also noted that at a previous visit before the call, the patient had requested repeat testing because she works in a meat factory. And she had read that exposures to animals can sometimes cause false positive results. And sure enough, when the lab director repeated the HIV and hepatitis B testing at that point, using something called a heterophile blocking reagent, which I'll talk about more in just a couple slides, both of those came back negative. Moreover, she reported that her partner had been tested for HIV at that point and was negative. So my next questions for you are, is this person infected with HIV? Yes, no, or not sure. And as a follow-up to that, would you continue their ART during pregnancy? Yes, no, or I don't know. Right? There's not an easy answer to either of these questions, I will tell you. All right. So I wanted to use this test because I think it's a great example of ambiguous test results. They actually occur more commonly than we would think in clinical practice. And they are just what they sound like, right? They are results where the presence or absence of HIV cannot be clearly established based on the usual HIV diagnostic algorithm, as we have just seen in this case. The CDC gives some specific examples as well, including a positive HIV antigen antibody test followed by an indeterminate HIV-1-2 differentiation assay in somebody who doesn't have recent ART exposure, or a positive HIV antigen antibody test, but a negative RNA test, or vice versa, in somebody who has recently been exposed to antiretrovirals. So why do these occur? It's a tough question, and there are a number of different potential etiologies that need to be considered in each case. One is laboratory error. That's always a possibility. The second is the window period, as I had discussed earlier. Also, as we are learning, exposure to antiretroviral therapy, particularly in the form of pre-exposure prophylaxis, and especially in the form of long-acting PrEP, can definitely impact ART testing results and lead to confusing patterns. Exposure to an HIV vaccine can also do the same. And importantly, and particularly relevant to this case, and any case where a person does not have prior ART exposure, we think about the most likely cause being something called highly cross-reactive heterophile antibodies. And these highly cross-reactive heterophile antibodies are endogenous antibodies present in human plasma that are produced in response to a variety of different triggers, right? Those triggers can include things like vaccines, including the influenza vaccine and potentially the COVID vaccine. They can include recent illnesses such as EBV, COVID illness, and malaria. And there are also other conditions that can lead to the development of these broadly cross-reacting heterophile antibodies, including pregnancy and autoimmune disease. And The manner in which, the mechanism by which they cause false positive tests, I think is very nicely depicted by the picture in the bottom right of this slide. So let you take a look at that. But basically, these are really sticky antibodies, right? These broadly cross-reacting heterophile antibodies stick to everything, including the reagents, the antibodies that are used as part of the testing platform, leading to these false positive results, even in the absence of the test analyte. And the next thing I'm going to tell you is probably one of the most important things for you to take away from this presentation, which is that 95% of specimens that are repeatedly reactive on one screening platform will end up being negative when retested on a different platform. So remember when I gave you that slide that showed the big instrument, we talked about instrumented versus point of care testing, right? It turns out that there, as I mentioned briefly, there are a number of different platforms that can be used with instrumented testing. And so if you just call the lab and find out which one they're using, and then call a different lab to make sure that they're using a different one, send it to that other lab, 95% of the time, you're going to get a different result, and that will resolve the situation. Another thing that you can do is you can add these reagents called heterophile blocking reagents, because those will reduce or eliminate false reactivity. And essentially, if you look at the graph or the picture on this slide, you see that heterophile antibody that's binding to both the capture and the label antibody. What these blocking reagents do is that they take them out of circulation, essentially. They take these heterophilic antibodies out of circulation so they can't bind with the testing platform antibodies. And just to circle back to something that the patient herself had mentioned, it turns out that occupational exposure to meat products can, in fact, elicit the production of heterophile antibodies, leading to false positive tests for both HIV and viral hepatitis. So she was absolutely correct about that. All right, we're going to fast forward now a couple months. You're called overnight because this, by the pediatric team now. The infant of this patient was delivered by normal vaginal delivery a couple hours ago, and the pediatrician is calling because they had received sign out from the maternal HIV provider saying that they think that the infant should be put on AZT for 6 weeks. And they had talked to the mother and decided that it was okay to breastfeed. The overnight peds attending advised the patient actually to pump and save until they were able to clarify prior breastfeeding recommendations and current test results. And they were calling us because they wanted to know what is the role of ARV prophylaxis for this infant while awaiting further clarifying information. And so I'm going to take a small detour and show you what the current DHHS guidelines recommend when the HIV status of the mother is uncertain based on limited testing at the time of labor and delivery. And they actually recommend a very conservative approach. The scenario that they describe here is a little bit different than the scenario we've described in this case. They're talking mostly about people who present to labor and delivery without any prior HIV testing and then have a positive rapid test in labor and delivery. That said, the general sense from the guidelines is that when the maternal HIV status cannot be clearly elucidated, then ARV prophylaxis should be provided to the infant until that status can be further clarified. However, I also want to note that informed decision-making should always guide our discussions in these situations. There are scenarios where it would not be unreasonable not to provide the infant with ARV prophylaxis based if there are previous similar patterns in terms of the test results. And just to kind of wrap things up with this particular case, what we talked with for the provider here was that yes, it did make sense to actually give the infant AZT, at least initially. for prophylaxis while clarifying the maternal HIV status. The first thing that we recommended was repeating that HIV test on a different platform. And if that was negative, then you could actually stop infant ARV prophylaxis. If it was positive, we recommended continuing it until additional testing could be done on the mom to further clarify her status. And I promise I will get to what some of those additional tests are when you're facing this conundrum in just a couple of slides. All right, so now I'm going to transition to our last case. And I'm highlighting this case for a couple of reasons. One is because I think it's a great example of some of the diagnostic perils that we are experiencing now in the era of long-acting pre-exposure prophylaxis. The second is because it also highlights a pretty cool collaboration between the NCCC, the CDC, and the SeroPrep study, which for those of you who are interested, I can describe more about at the end of the talk. So this is a call that we received from this case describes a call from somebody who was working, a provider who was working in a high volume pre-exposure prophylaxis clinic. And he was caring for a 23-year-old non-binary adult who had recently presented for a repeat LA CAB injection. He had, according to the caller, this person had previously been on PrEP at a different facility, but did not have records. They had their initial enrollment visit at the caller's clinic on May 10th. And at that point in time, both the HIV antigen antibody and the viral load came back negative. 20 days later, they received their initial injection, at which time they also had a negative rapid antibody test done. And then on June 27th, they came back for their follow-up injection. And at that point in time, they had a antigen antibody test and viral load drawn and sent to the lab, and the injection was given. No rapid test was done at the time. The caller is calling you because the lab reported the HIV antigen antibody result as a low-level positive. And to be honest, that's the first time I've ever seen that result, that type of result. And they also had an HIV viral load of 451. Additional history of note, according to the patient, they had 4 sexual partners, all of whom were known to them. They also said that their main partner had been on PrEP consistently, but had elected to stop it for about 1 week before the patient themselves received their first injection on May 30th. So do you think this person is infected with HIV? Yes, no, or not sure. Yeah, so again, tough question, not totally apparent, although I think maybe a little bit more apparent than for the pregnant person that we recently discussed. So again, this is a great case of some of the challenges of diagnosing HIV in people who are on pre-exposure prophylaxis. And because of cases like this that were seen in the HPTN 083 study, the CDC PrEP guidelines modify their testing algorithm a little bit for people who are planning to start PrEP and for those who are on PrEP. So I wanted to walk through these with you briefly. For people with no recent ART exposure of any kind, they recommend doing the standard assay, which is the HIV antigen antibody with reflex to confirmatory differentiation. If, however, there is concern that the individual in question may have had a recent HIV exposure, or if they have signs or symptoms of acute HIV within the previous 4 weeks, or if you're planning on using injectable pre-exposure prophylaxis, they do recommend obtaining an RNA simultaneously. So at the same time that you send off that antigen antibody test, because remember the window period for the RNA is shorter than it is for the antigen. Okay. For people who are already on pre-exposure prophylaxis or who have recently had exposure to ART in some form, because whether it was PEP or past experience with pre-exposure prophylaxis, They again recommend doing an antigen antibody test and an RNA simultaneously for all of these individuals. And what they say is that if both are positive, then you can confirm HIV infection. If both of these results are negative, then there's no HIV infection. And if one is positive but the other is negative, then this is considered an ambiguous test result, so additional testing is recommended. The additional testing that they recommend actually is just repeating the nucleic acid test. It can be a qualitative or a quantitative test. Just a quick aside as to the differences between the qualitative and the quantitative. Again, quantitative viral loads are what we have historically used to monitor people on treatment. The qualitative viral loads, particularly those that have a diagnostic claim, those recently approved by the FDA for HIV diagnosis, are more sensitive, all right? And so oftentimes in a situation like this, we would recommend doing the qualitative RNA test to help sort out the diagnosis. It is still possible, though, that after all of that testing, the diagnosis may remain unclear. And so there are additional tests that you can do to further clarify. And some of what other tests that we often recommend include the HIV Western blot. That used to be part of the standard HIV testing algorithm. Alice is nodding her head. I remember those days as well. It's much harder to find labs that do Western blot testing nowadays. The one commercial lab that I'm aware of that does it is ARUP, but you have to have an ARUP facility in your area to be able to get it. The CDC will also do it if you ask their permission. Additionally, you can do proviral HIV DNA testing, and there are a couple of different forms of proviral testing that you can do. You can do a qualitative viral load, as we do to diagnose which is one of the recommended tests to diagnose infants who have perinatal exposure. And the other option, because that actually is also sometimes difficult to obtain, the only lab that I know of that does that is Quest. If you don't have that available to you, you can do ultrasensitive HIV DNA sequencing, which is also known as the archive genotype, which Monica and Alice were just talking about, because as part of that test, they actually have to do they have to amplify the HIV DNA. And so if there's no HIV DNA present, they won't be able to run the test. All right, so that is kind of a sneaky backdoor way to see if any HIV DNA is present in that individual. All right, so to wrap things up with this particular case, if it sounded familiar, I'm sure it sounds familiar to Monica because she's one of the PIs on the SeroPrep study. It was actually recently presented at CROI by Dr. Kate Koss. This is actually the first case of HIV seroconversion with INSTI resistance emerging as a result on LA-CAB in routine care. It was presented again at Denver this year, and this person was confirmed to be HIV-1 infected and was also found, unfortunately, to have INSTI resistance, meaning that, and importantly, had the 148, which Monica has already mentioned, rules out dolutegravir as a viable option for treatment in this person, unfortunately. So to summarize, my presentation for today, HIV testing remains underutilized here in the US, as we heard. When choosing which test to use for your specific clinic or program, it is important to kind of remember what some of the differences are between the different platforms that can be used, know what the advantages and limitations are, and how those best fit in with your needs and the needs of the community that you're serving. Remember to follow recommended testing algorithms to their completion. And when results are uncertain or ambiguous, review the guideline recommendations on how to proceed. If you're not sure, you can always call a local expert for help or call the NCCC. And that's it. I have acknowledgements. These are all the numbers of the different consultation services that we provide at the NCCC. And I'll leave this slide up because this is the slide that describes the collaboration between CDC, NCCC, and SeroPrep for people with who have potentially have breakthrough HIV infections while on PrEP.
Thank you so much, Chris. This is exactly what we wanted. We've had a lot of questions. I'm looking over at my intake people, wherever they are. We get a lot of these from syringe exchange programs, pregnant women, and these are tough. And just to reiterate what you said, Dr. Van Sickles is always telling people to call the NCCC. And so we've gotten a lot of good help. So thank you. Do we have any questions, Drew, online?
Nothing online, no.
Any in the audience? Yes. I'll let Drew get over there to you. He's over here, Drew.
Sorry, who was it?
Right here.
Oh my God.
Our pharmacist. It's our pharmacist.
I got you.
We've got the virtual.
Yeah.
Hi, Antonio again. So I was just curious about what's the like the fiscal damage of all this, right? Because I work in an FQHC where, you know, we kind of just scrape by on, you know, change in your pocket, and we do HIV testing and we have to send our confirmatory testing off. But once I see your algorithm, I'm like, holy, that's a lot more testing. Like, do you know just kind of the financial aspect of that?
Yeah, that's a great question, and it's one that we get a lot. And I will tell you that although the PrEP guidelines recommend doing viral load testing for everybody who's on PrEP, whether it's oral PrEP or long-acting PrEP, I think that you do not need to do the viral load testing for people who are on oral PrEP. I do think because of the data that we've seen from 083 and now as we're seeing emerging in the real world, that it should be done for people who are on LACAB.
Have any other questions?
Did you give the answer to the meat packing lady?
Oh, go ahead.
Is
Chris.
she HIV infected or not? I didn't, because I actually don't know. I don't know what happened. We
You wanna
did.
repeat just in case
Sorry,
people-
I did not give the answer to that question because I personally do not know the answer. Yeah. We did connect the provider with Dr. Jeff Johnson, who was mentioned on my slide deck as in one of the acknowledgements at the CDC. We left it to them to sort out the diagnosis. So I'm not sure how it ended. That's one of the I mean, I love working at the NCCC. We get a lot of really interesting cases, but one of the disadvantages is that we don't always get follow-up as demonstrated here. And I apologize that I don't have a definitive answer as to whether or not she was infected. I think she was not. I think, you know, most of the evidence points to her test results being false positive results, but definitely confusing patterns. Yes.
Wait just a second. Can you go over, Drew? No, because we got virtual. We got virtual people. I want to make sure they can hear.
Thanks. I just wanted to make a comment to piggyback on what you said and to answer your question about the extra testing. Our ID group at Montefiore in the Bronx, we actually wrote a paper and submitted to Foreman Infectious Diseases on the point of everybody on PrEP needing a viral RNA. And even some were suggesting you do a viral RNA and an HIV antigen antibody combo, which I don't understand why you need to do both for people who are on oral PrEP. So we actually made the case for only doing the standard HIV antigen antibody for people on oral PrEP and doing the viral RNA for people on LA injectable for the reasons and the data that you mentioned. So you don't need to do those, and we made a great case for it. So don't need to do that extra testing.
Yeah, we do get that question a lot. And I think that one of the most important things to think about from a clinic management and fiscal perspective is, if the added cost of testing is going to severely limit the number of people that can be on PrEP, then you probably shouldn't do it. right? It's more important to get people on PrEP, right? I think that's the priority. It's more important to get people on PrEP.
I think we got, Drew, we have one here. Our pharmacists are actually asking good questions. It's right here.
What? Oh, there we go.
Hello. So please forgive if this was already covered because I unfortunately had to take a call before your talk. But the importance of home testing and the availability of now free home tests, and what do you do if someone brings you a home test that is positive, and how do you navigate that space knowing that it's an antibody only test?
Right.
And then obviously on top of that, potentially having a mail-in self-collected STI screening also being part of that
Yeah.
ecosystem for those who maybe may not want to use the traditional healthcare system or don't have access to it because of their work schedule.
Yeah.
So I live and work in Las Vegas, and we have a ton of shift workers, and the clinic's just not open when they're
Mhm.
available. So having these alternative access points, like having the ability to do home testing, is really important for those folks to get engaged in care. And so I'm just curious, like, where is that at in your algorithm?
Yeah, so I would say that most home-based tests would fall into the same bucket as the point of care tests, right? In terms of how we utilize them. They have a role. They definitely have an important role. It is the other important consideration, though, is that for the saliva-based tests, right, those are less sensitive. And so if it's somebody that you're considering starting on pre-exposure prophylaxis, you shouldn't use the result of a saliva-based test alone to determine whether or not it's safe to go ahead and start that person on pre-exposure prophylaxis.
Great questions and great answers. Anybody else? All right. This team, is there anybody else, Drew? I'm looking at Drew. All right, thank you so much.